Fantastic. Perhaps Professor Endres, would you, shall I hand over to you, and then you can do the introductions? Thank you.
Great. Dear colleagues, it's a great honor for me to be part of this journal club today. My name is Dominique Endres, and I'm a psychiatrist in Freiburg in Germany, and I'm very interested in autoimmune psychiatric syndromes. And in this context, we have also created a nationwide database to collect such cases. And I'm very happy that you want to discuss our first evaluation from this database today. Even if this work has surely several limitations, it can be an interesting starting point, I think. And I was also asked to introduce Professor Belinda Lennox from Oxford. She has been a great role model for me all the time, and I think all of you know her. She's one of the most famous researchers in the field of autoimmunity worldwide in psychiatry, and therefore I think it's wonderful that she is also participating in this journal club today. And with that, I would like to turn the attention over to Professor Belinda Lennox and Dr. Hamilton Maureen, who is presenting today. Thank you very much.
So I'm just uploading the slides now, but thank you very much for coming, everyone. Just to clarify, I'll be presenting for the first half, talking about this fantastic research paper by Professor Endres and his colleagues, and then afterwards we can have a bit of a group discussion with everyone. But yes, so it's a real delight to be able to present this paper. As you can see, it's a case series of 91 patients from Germany and reporting on clinical manifestations and immunotherapy experiences in psychiatric patients with suspected autoimmune encephalitis. And I think to start with, it's always good to have a bit of background. And I'm certain many of you in the audience, like myself, are fans of a good mystery. And of course, 3 years into the global COVID-19 pandemic, whilst we've learned a lot, there's still a lot of mysteries that remain, particularly with regards to long-term effects with long COVID. And I'm sure for many of you, it's hard not to be reminded of previous epidemics, and one that no doubt comes to mind is that of encephalitis lethargica, which has previously been described as the greatest medical mystery of the 20th century, and which was quite nicely represented and immortalized in a fantastic book by Oliver Sacks titled Awakenings, which has his experiences of treating individuals with encephalitis lethargica and the profound impact it had on individuals, their lives, and society at large. And of course, they also made a film of this book starring Robin Williams. And myself, I do enjoy a good book. And more recently, I say recently, but actually 10 years ago, a light was shed on autoimmune encephalitis in the book Brain on Fire, written by New York Times journalist Susanna Cahalan. And it's quite an interesting read, actually, because this is a first-hand autobiographical report of the experience of having anti-NMDA receptor autoimmune encephalitis, which is one of, if not the most common forms of autoimmune encephalitis, and it was first described in 2007. And it's not only an interesting report of what it's like to experience the symptoms of the condition, but also about the profound difficulty, and especially at the time of gaining a diagnosis, in that there was a real lack of awareness of the condition amongst clinicians, and it was quite an arduous process for her. Of course, they've made a film of this book as well. I have to say, the film isn't quite as good, but the book is certainly worth a read. And I just wanted to draw attention to a few lines from the book in which Susanna talks about how, as a result of the autoimmune encephalitis that she experienced, that she'd lost confidence and the sense of self. She talks about experiencing fear and uncertainty about who she was, and having this real confusion about her pathway in terms of illness and recovery, and experiencing a great degree of shame and the belief that she would never be herself again. And there's this one line in particular that I quite like, which is that we are, in the end, the sum of our parts. And when the body fails, all the virtues we hold dear go with it. And I think personally what I take away from this is that there's a real sense of loss in terms of what one can experience with going through autoimmune encephalitis. But at the same time, and in particular that last line, I think it speaks a lot to the, well, not only does this speak to the experience of the symptoms of perhaps paranoia and psychosis, but it also speaks to the how the condition itself challenges the public perception of a Cartesian dualism between mental and physical health, and that actually they're both closely entwined. Now, of course, this book that I just mentioned did a good job at bringing the public eye towards autoimmune encephalitis. But in addition, there are charities that are doing fantastic work in terms of raising awareness regarding encephalitis, including the Encephalitis Society. And every year in February, there is World Encephalitis Day, which is designed to increase public awareness of different forms of encephalitis, not just autoimmune. And I have to say, well, I do quite like their infographics, that, quite easy to understand and take in. But I was quite surprised by the figure that 78% of the general public don't actually know what encephalitis is, which is interesting because I suppose if you speak to a member of the general public, they might know more about meningitis. But encephalitis, I think there's still a lot of mystery regarding the condition. And so focusing a bit more on autoimmune encephalitis, because the study in question is focused on autoimmune encephalitis. Interestingly, whilst perhaps it may have been thought of as quite a rare form of encephalitis, actually epidemiological studies have suggested that it may be as common as infectious causes of encephalitis. And I mentioned before, but the most commonly identified form of autoimmune encephalitis is NMDA receptor autoimmune encephalitis. Interestingly, there have also been studies assessing and comparing patients with psychosis to the general population, and it's been found there's a higher rate of NMDA antibody positivity in serum in those with psychosis compared to the general population. And there's also been a previous study that found a higher prevalence of neuronal antibodies in patients with psychosis. And of course, it's questionable. What the question is, what is the clinical significance of this? But it's still an interesting observation. Now, focusing specifically on NMDA receptor encephalitis, because of course there are various forms of autoimmune encephalitis, but in terms of disease process, antibodies bind the NMDA receptor, leading to its internalization and a general state of hypofunction of the NMDA receptor. And it's been known for some time that NMDAR antagonists can lead to schizophrenia-like symptoms, mimic schizophrenia. And so the idea is that if NMDA receptors are underactive, then tonic inhibition of the mesolimbic dopamine pathway doesn't occur. And this leads to upregulation of the, or this leads to hypodopaminergia and upregulation of the mesolimbic dopaminergic system with the classical positive symptoms that you might get with psychosis. As I've mentioned, there's various different forms of autoimmune encephalitis, but commonly they have subacute presentations with often with psychiatric symptoms, which can further develop with neurological complications such as seizures and movement disorders. And in the case of NMDA receptor encephalitis, classically it's seen mostly in those under 45. There's a ratio of 4:1 in men compared to women compared to men, and there's a strong association with ovarian teratoma as well. Now, in terms of criteria that exist already for classifying and diagnosing autoimmune encephalitis, in 2016, Grouse and colleagues proposed diagnostic guidelines and criteria for possible autoimmune encephalitis, as well as definite NMDA encephalitis. And these criteria, are often used, but more recently, in 2020, Pollock and other colleagues put forward a position paper with consensus-derived diagnostic criteria for possible, probable, and definite autoimmune psychosis, as well as red flags for autoimmune encephalitis in patients with psychosis. Of course, now I've given some background. I think it's about time to come onto the paper itself. But I think in terms of why I chose this paper in particular, one thing I found quite interesting was learning that actually in Germany, psychiatry trainees are expected to do a rotation in neurology, and vice versa, neurology trainees also spend time in psychiatry. And I know this is something that would certainly be quite popular in the UK. But in addition, the relationship between neurology and psychiatry is from what I've understood is a much closer one. And services are organized in such a way that patients with a first episode of psychosis can undergo neurological investigations more readily compared to here. Now, this paper was published in the journal Molecular Psychiatry, which has an impact factor of 13.4, so it's a strong impact factor there. And this may be, well, this is clearly an oversimplification, but generally the aim of this study can be said to be that of characterizing a population of psychiatric patients with autoimmune encephalitis, and through that process identifying common clinical features and investigation findings in autoimmune encephalitis, as well as assessing for response in immunotherapy. And it should be noted that this is specifically in patients with just psychiatric symptoms. And again, I think this ties into the theme of mysteries, because perhaps, you know, it's a bit more clear-cut when there are clear neurological features such as seizures, but it's a bit more diagnostically challenging in their absence. Now, in terms of the methodology of this study, it was a retrospective study conducted nationwide across Germany, with patients being data being collected from over 20 different inpatient settings. And following screening, data was entered, anonymized, and reported through the German Network for Research on Autoimmune Encephalitis, GENERATE, which is a fantastic collaboration, and something that I think would benefit from having something similar in the UK as well. Now, essentially, apologies, seems to have skipped, having some technical issues. There we go. The inclusion criteria for this study were relatively broad, but meant that the researchers were able to get quite a large and useful data set. But specifically, as I mentioned, it was patients with predominantly psychiatric symptoms, and who also showed any one of the following findings. And these were neuronal antibodies against cell surface antigens or glial antigens, antibodies against intracellular neuronal glial antigens, antibodies against thyroid antigens, and a clinical response to any immunomodulatory therapy, and inflammatory changes in CSF or clinically relevant response to any immunomodulatory treatment. And as I've mentioned, they chose to exclude patients who had a more clear clinical picture of autoimmune encephalitis, such as tonic-clonic or focal seizures or loss of consciousness. Interestingly, movement disorders didn't lead to exclusion if they were deemed related to the psychosis. So, for example, in the case of catatonia, and dementia and pseudodementia syndromes were considered psychiatric syndromes for this study. Now, the two main subgroups that were formed for the purpose of data analysis in the study were that of probable psychiatric autoimmune encephalitis, in which patients had psychiatric symptoms and detection of well-characterized neuronal antibodies against cell surface or glial antigens, such as NMDAR receptors antibodies. And this was notably in both serum or CSF. And otherwise, patients were deemed to have possible psychiatric autoimmune encephalitis with antibodies for non-well-characterized neuronal antibodies, as well as or clinical response to immunomodulatory therapies with or without detection of antibodies or detection of inflammatory CSF pathologies. And whilst these were the main two subgroups that were used for the purpose of describing results, the authors did also report 4 other subgroups in their analyses, further subgroups of patients with antibodies against cell surface antigens, patients with antibodies against intracellular antigens, those with probable Hashimoto encephalopathy, and those who are seronegative but with potential psychiatric autoimmune syndromes based on inflammatory CSF alterations and or response to a trial of immunotherapy as rated by a treating doctor. So on to the meat of things, which is the results. As you can tell from the title, 91 patients were identified, 21 of whom were deemed to have probable psychiatric autoimmune encephalitis, and 70 of whom were deemed to have possible. Now, in both groups, the majority of patients were deemed to be suffering from paranoid hallucinatory syndrome, so schizophrenia spectrum disorders, as it were. And the most common psychiatric symptoms were those of affective symptoms, as well as altered energy and psychomotor activity. Now, there weren't any significant differences in both groups in terms of gender or age, though it was noted that women were slightly overrepresented in the probable group, which is perhaps to be expected in terms of the epidemiology. And similarly, patients with possible cases were tended to be older. Now, in terms of clinical features that were observed, there was a significantly more frequent disorientation and impaired memory observed in those with probable psychiatric autoimmune encephalitis, as well as autonomic dysregulation. And there was a non-significant tendency for visual hallucinations. And this is, partly in keeping with already recognized and outlined red flag features for autoimmune encephalitis that have previously been discussed in the literature. What's more, pre-existing psychiatric conditions were almost half as common in those with probable autoimmune encephalitis as opposed to possible. Now, the most commonly found antibody was that of NMDA antibodies. And again, this is to be expected in terms of it being the most common form of autoimmune encephalitis. Interestingly, in the probable patient group, 90% were found to have serum NMDA antibodies. And of those who had lumbar punctures, 74% were CSF positive, which actually is quite a high proportion. Often in the literature, it can be found that patients may have high serum, there can be high prevalence of serum antibodies without also having antibodies in CSF. So it seems that what was occurring systemically, potentially was also occurring more centrally in the nervous system in this case. So and otherwise, antibody analyses were for more overall in probable autoimmune encephalitis compared to possible, and pleocytosis was the most common pathological finding in general in CSF overall. Quite a number of other investigations were carried out, which was quite good. Over half of those who had MRI scans were shown to have alterations, and over half of those who had FDG PET scans had alterations. And it's quite important, actually, that even though what one may say it's only 27, this is I would say this is perhaps more than is actually done in clinical practice, and it's quite important that it's done, as it's often overlooked. And there's increasing evidence that FDG PET has an important role in the distinction of psychiatric symptoms of autoimmune origin. But yes, there was no significant differences between probable and possible autoimmune encephalitis in terms of the investigations. Now, in terms of the immunotherapy, the majority of patients received immunotherapy, 69%, and improvement was observed in 93% of probable cases and 80% of possible cases. This most commonly came in the form of steroids, and was IV steroids in over half, and low-dose oral in 38%. I noted that improvement was more frequent in low-dose oral steroid, very small difference, but perhaps this might be indicative as well, potentially of this being used more often in less severe cases. Otherwise, there were other forms of immunotherapy used, such as plasmapheresis and IVIG, as well as rituximab being used as well. In terms of further subgroup analyses, I think the main takeaway was that there was a female predominance in Hashimoto's encephalopathy, which is again in keeping with epidemiology, with autoimmune conditions often being seen more commonly in female populations. And there was a significant difference in terms of CSF overall alterations and inflammatory pathologies amongst the 4 additional further subgroups that were outlined. Now, of course, this is a fantastic study and an essential one in terms of characterizing autoimmune encephalitis, specifically of the purely psychiatric phenotype. But no study is without limitations, and of course the authors actually acknowledge these limitations within the body of their discussion. Because of the nature of data collection, there's a degree of observer bias, as treatment response was determined from physician-based assessments rather than through, say, systematic follow-up or quantitative outcome data. What's more, there was selection bias, of course, as part of the inclusion criteria was immunotherapy response, and therefore the successfully treated patients may be more likely to be included in case collection. In addition, it can be argued that the inclusion criteria were quite broad, particularly with the probable subgroup also including patients with serum antibodies but without, say, CSF antibodies. But were this not the case, it's likely that the study population would have been a lot tighter and more restricted. And in addition, and it's acknowledged, but there was heterogeneity in terms of some of the investigations carried out, but of course this is likely reflective of reality in terms of clinical practice. Of course, this isn't a randomized controlled trial, but it is always nice if adverse effects can be reported alongside treatment outcomes where possible. In terms of clinical significance, however, of course, there's quite a few points raised in the discussion and elsewhere, but I think it is quite interesting. Sometimes there can be a tendency, if there are pre-existing mental disorders, where there's a belief that precludes or rules out autoimmune encephalitis, but in this case, almost half had prior mental health history. In addition, disorientation, impaired memory, and visual hallucinations were seen more in probable autoimmune encephalitis, and it may be the case, whilst the former 2 are recognized already as red flags, visual hallucinations might also be a suitable potential red flag in the future. Compared to previous studies, there was actually a higher frequency of NMDA antibodies reported, and as I mentioned, there was quite a high proportion of CSF antibodies observed in those with serum NMDA antibodies, which is quite notable and should be pointed out. And the authors also argue that the fact that there's not a significant difference in immunotherapy response between probable and possible might suggest that it shouldn't be limited to patients with currently known neural antibodies. I think also, it goes without saying, but GENERATE is clearly a valuable clinical and research resource, and the UK would certainly benefit from a similar autoimmune encephalitis research network. So, of course, there's a need for prospective studies going forward to build upon these findings. It sounds like, given close ties between neurology and psychiatry in Germany, it may be the case that it would be good for these studies to continue to take place going forward in Germany as well. And I think it is interesting as well. I'm sure many present in this meeting might be aware of a recent paper, systematic review that was published on NMDA autoimmune encephalitis, which found that those with CSF antibodies were more likely to present with psychosis and investigation abnormalities compared to serum only. So, it's a developing field, and there's a lot of ongoing interest. But I think that the main takeaway, especially for clinicians and those in training such as myself, is one should always consider testing for serum and CSF antibodies in any patient who's presenting with psychiatric disorder where perhaps there are red flag features such as cognitive disturbance or neurological features. But yes, thank you very much for listening to me waffle on about this talk. This is the bibliography and just some supplementary materials. But yes, thank you very much.
Thank you so much for this wonderful overview, Dr. Morin. It was great to hear to you. A great pleasure to hear to this overview. I think we can open the discussion now. Perhaps I will start with one comment, if it is okay, because I was asked for that. I think what we can learn from this data is that the spectrum is also broader than psychosis, because most of these patients had an autoimmune psychosis, but some of them also had an autoimmune depression or other psychiatric syndromes. And this is also what we see on our ward. I'm, for example, responsible for the OCD ward, and I was very surprised that we also have autoimmune OCD patients there. These are rare patients, but we find them if we look for them. And on the other hand, many of these patients were antibody negative. This is also an important fact. So we still have to understand what these patients really have. And I think that some of these patients might have novel psychiatric antibodies. So this shows the further need for research in this, in my opinion, very interesting research field. Perhaps Belinda Lennox has to comment now.
Yeah, I'm really happy to, and I'm delighted to be here to discuss this paper, because actually I think this is a really important paper for all the trainees listening, and I really hope this helps to accelerate and transform our clinical practice, because I hope it sort of challenges us quite a lot, because there's no reason why these patients described by Dominic and colleagues in Germany shouldn't be absolutely amongst our services in England as well, and we're not testing and screening, we're not looking for them at the moment. So I suppose the reasons I suppose this is such an exciting paper for me is that before this paper, we would find patients with serum NMDA receptor antibodies, and we would get the message from some neurology colleagues that these were likely clinically irrelevant, because it's only antibodies in the CSF that count and that matter for the sake of having a treatable disorder. So Dominic's study shows that this isn't true. So that actually most of the patients with a serum antibody did have CSF antibodies, but even those that didn't have CSF antibodies, they still responded to treatment with immune therapy. So that it's not essential, essentially, to have the antibody in the CSF, but much more than that, that even without a serum antibody, that actually a good proportion of patients have inflammatory changes in their CSF. So even with a negative serum antibody panel, there is value in investigating, and particularly in doing lumbar punctures. So it is really that it's the inflammatory changes, the raised white cells, the raised protein levels, you know, it's these changes in the CSF that really indicate that different treatment approaches are required. So, I mean, and that really is the sort of take-home message, I think, that we've just got to be doing this. And many more of their 91 patients were antibody negative, but with inflammatory changes that were still immune responsive. So it's the tip of the iceberg. It really is these known, recognized antibody conditions. I mean, you mentioned some of the limitations. I suppose just to be fair and to be, you know, in the proper journal club, it's worth mentioning just a couple of others, Hamilton. So, of course, all of these patients were all treated with psychiatric medications as well. So we can't actually clearly say that it was the steroids or it was the olanzapine, really. Of course, everybody knew what they were getting as well. And actually, steroids makes everybody feel a bit kind of better. So, you know, I mean, so there's a significant placebo effect with these medications as well. And there's no way of knowing the sort of the denominator. So these were selected cases fed into the Generate database by clinicians. So we'd no idea the sort of substrate of the many thousands of patients that were seen that these were selected from. So we don't know if they're, you know, how rare they are essentially from the prevalence basically from these data. But we do know, have some indication from James Scott's study, for instance, from Brisbane of the prevalence rate. So he screened 113 sequential inpatients for antibodies and found 6 with antibodies, 4 with NMDA receptor antibodies, 2 with ovarian teratoma, and amongst the most unwell patients on the PICUs. But, you know, that gives a prevalence rate of what, about 5% of patients. That's just psychosis in that instance. No one's done that study for OCD or for other mental disorders. So this isn't, I don't think this is so rare that we can ignore it or leave it to others. I suppose those are the key points that I sort of wanted to highlight, but I'd be really interested in other people's thoughts.
Thank you so much for these comments. This is a very important point. This was a pre-selected cohort of patients, and this is surely the reason why we had so many patients with CSF antibodies, because we especially looked for them. And this, the inflammatory CSF signal was one of the inclusion criteria. And another very important point is that this was no placebo-controlled trial. But this is something Belinda Lennox is doing, and we are very interested in her results coming soon. But I see there are further questions. I don't know how the procedure is now, but we are open, I think, for all this question, right? Aren't we, Dr. Hamilton?
Yes, but perhaps we can take questions from people with their hands up first, and then address some in the chat. Tim, I can see you have your hand up.
Hi, I think my camera's taking a while to come on, hopefully it will, but hi Belinda, hi Dominic, hi Hamilton, great, oh I think we're working, yeah, great presentation of a really interesting paper, and just going to make a couple of observations. I guess just agreeing with Belinda, I think, you know, we really need to start investigating psychiatry patients thoroughly as a brain disease that needs, and it's going to require a sort of culture shift and some practical, you know, it's not an easy thing to do with acute mental, you know, acutely mentally ill patients, but I think that's really, really important. But I guess my sort of question was really on these interesting observations of the effective symptoms, both before the encephalitis and then the effective symptoms being the most common that you found in this group. And I was just wondering if you have sort of detail of, you know, the sort of fine level detail of the psychopathology. Is there anything distinct? Are there unusual mixed affective states or something? Is there anything unusual about that you could determine or have a hunch about? And again, whether Belinda's got any clinical intuition here about anything different about either those prior affective states people might have had and then the ones during the acute illness, and whether there's anything to learn about how we could inform us to help pick up patients and enrich our, you know, cohorts for finding and identifying and treating these patients better. So that's a question for I guess all of you, but I'm not sure, perhaps Dominic first.
Yeah, thank you. This is a very important clinical aspect. It's hard to get information from this data, but from my clinical point of view, as a clinician working in psychiatry and looking on these patients, I think the patients with a very acute onset are important patients, acute onset of a polymorphic psychiatric and psychotic syndrome. And on the other hand, the catatonic patients should lead us surely to do further analysis. So I think these two things should be important take-home messages from my clinical point of view.
Right, and I think, Linda, you've just put the Adams paper in, which is brilliant, isn't it, with the lovely image of the psychopathology, but I guess there's presumably a lot, you know, the detailing is really interesting, but what, any observations clinically as well beyond that data?
Yeah, and the trouble is there's a sort of circularity in that it's only when you then have the encephalitis diagnosed you look back at the psychopathology rather than doing a sort of systematic screening and then looking at the actual patients that test positive in a more sort of you know, population level. And the ones that I suppose, because we are doing that screening study, you know, have done for several years. And I think the key things, as Dominic says, is the abruptness of the onset is really the thing that stands out for me. These aren't the patients that have had decline over weeks and months. You know, these aren't the adolescents who smoke a lot of cannabis and drop out of school. These are the previously fit well, often young women who have a bit of a viral kind of illness, and then a few days later have a severe you know, florid mental illness. So, and often with a sort of a mixed affective, psychotic, very behaviorally disturbed kind of presentation, often catatonic as well. Yeah.
Brilliant. Thank you.
I can see that Cameron Watson has his hands up.
Yeah, my camera is also taking a little bit while to come up, so I'll leave you in suspense there. But thank you, Hamilton. It's a really fab demonstration of an excellent paper. I know this is really cheeky and probably goes against Journal Club rules, but I do have two questions. One's very quick. I wondered what the method of trying to identify the primary malignancies was. Was that also PET scan? Was it full body PET?
Should I answer? It was not done systematically,
okay,
because this was a retrospective cohort, and these were pre-selected cases from different hospitals all over Germany, and we collected them, or we asked all the colleagues to collect these patients, but there were different methodological approaches. But this should be done in the future to do this prospective, but this was not done here.
Okay, great. And then my broader question, I think, has been picked up quite a lot in the audience as well. I'm a CT1 trainee and was fairly fortunate to do a few lumbar punctures as a neurology SHO before. And I know lots of people are talking about that now as trainees, for psychiatric trainees. I'm sure we're all very jealous of the German training program. With other things in psychiatry as well, I'm thinking Alzheimer's and monoclonal antibody therapies for Alzheimer's coming in, and even things like in neurodevelopmental disorders like copy number variants with psychiatric and neurological complications. How realistic is it to hope that, you know, brain health clinics are actually going to become the future of the NHS, or are we going to just keep being separated by a lack of ambition, I guess, in a way? I've been told I'm not allowed to do a lumbar puncture on one of my on-calls, so it's variable, and I just wondered what the appetite for it was amongst an already stretched service. Sorry if that's fairly cynical. I'm wondering for, you know, for all of our careers.
Well, I have to say, I visited Freiburg and I was inspired by the way that it's just absolutely routine practice over there. I don't know, Dominic, if you want to say a bit about your experience of the acceptability and the feasibility of doing lumbar punctures in psychotic patients.
Yeah, it is feasible. So most of our patients agree, but this is because we offer it to all our patients, and many patients are coming because they want to get an organic diagnostic workup, and it is something relatively normal on our ward. So it is normal for everybody, for the nurses, for the doctors, and for the patients. So it is a normal thing, and it is not very complicated to do that. You need an MRI before, but we still need it, of course, and then we do the lumbar punctures. So it is not a big problem. Sometimes it might be a problem because if you have a very acute patient, then we give neuroleptics to these patients. This might also be the reason why many of these patients got neuroleptics, because you have to explain the method to them, and it might be possible to do that, and they have to be able to agree to this procedure. But then it is possible, surely possible, to do it also in a psychiatric setting.
Yeah, and I suppose the other thing to say is that actually our medical colleagues, it's not the doctors that do the lumbar punctures, it's usually nurses, you know, the specialist training. It's absolutely using the sort of fine needles that they use nowadays. It really is a simple procedure, and it's not painful, or, you know, it's not unpleasant from a sort of a patient perspective. You know, my husband works in Swindon, which is a district general hospital, and he has a physiotherapist who's gone on a training course who does lumbar punctures in a side room. You know, it's absolutely normal medical practice. It's ridiculous that we don't just get on with it, really, I suppose, is my feeling. Cameron?
Fantastic. I can see there's a question from Jamie Badnock in the chat, which was, what was the temporality of prior mental health problems in people who developed autoimmune encephalitis? And is this likely to be contributory or a prodromal manifestation of autoimmune encephalitis?
Do you have any data on that, Dominic, on the previous diagnosis and temporal relationship?
I think I don't know the exact number we found, but many of our patients had a previous psychiatric history, and I mentioned this in this paper discussion very intensively, because we often have the problem in our neurology or in the internal medicine departments that colleagues say, okay, this is a psychiatric patient, and we don't have somatic diagnostic workup. And I think this might be a big failure, because even if you have a psychiatric history, you can develop an autoimmune encephalitis, or even perhaps it might be an increasing risk factor. We don't have the numbers. We need a bigger patient group for that. But this reflects, if people are saying, okay, this is a psychiatric patient, we don't have to look for these things, it might be a very big problem for our patients. I remember one patient, we did a case report about him. He had an alcohol abuse and a severe hyponatremia, and the colleagues, and he had epileptic seizures and an epileptic status, for example. And the colleagues said, okay, this is a withdrawal syndrome from this alcohol abuse, and they did nothing. And the patient was then severely ill. He developed a frontotemporal dementia, and I think 2 years later he came to us, and he had an LG1 encephalitis, and he still had a limbic encephalitis in the MRI, and an increased white blood cell count in the CSF. And this syndrome went into frontotemporal dementia, which was very bad for these patients. So I think it's very important still in these patients to look for an organic cause.
And I can see a question from Alana, which I suppose is an interesting one. It is that for patients where there is a response to immunotherapy, how do you consider the question of how long to keep them immunosuppressed?
Should I answer? Or
You
are the big expert.
I mean, we tend to treat people in the same way as sort of gathering information around how to treat encephalitis, basically. So it depends on the antibody a bit, but for the NMDA receptor antibody, you'd look for a teratoma, and if there isn't a teratoma, then you'd give people a good course of immunosuppression. So you'd remove the antibodies with IVIG or plasma exchange. You give a course of steroids tapering over a sort of 6-month period, and then you would consider, I mean, I think the current practice now is to consider rituximab pretty much straight away, and that's a sort of B-cell depleting drug that lasts for about 6 months, and then you would consider that would be it, that actually then it would likely be a monophasic illness and you'd be unlucky to get a relapse, and that seems to be what the evidence shows.
Thank you very much, Professor Lennox. I can see in the chat there are also comments as opposed to just questions, and some of them are interesting. Ali Rooney raises that perhaps the historical geographical separation of psychiatric and medical neuroimaging services in most places in the UK is a pragmatic barrier to getting an MRI or CT head before a lumbar puncture. And presumably this suggests that major centres where the two services are on the same site would be a good place to start with normalising lumbar punctures within psychiatry.
Yeah, I think that's an excellent point, absolutely.
Here's another one from Rachel Bora, which you might know, Dominique, but were there any reports of any exacerbation of psychotic symptoms in those patients who did receive high-dose IV steroids, specifically perhaps if they were in that possible group?
Yeah, this is a very, very important point. And we all know this risk of also getting depressive symptoms in these patients. And I think if you have a patient with an autoimmune encephalitis, most of them will have a positive effect on the treatment. But if you will treat a patient with a psychosis without any brain inflammation, I think the risk might be much, much higher. So it's very important to do a clear diagnostic workup and to select patients who have a brain inflammation, because then we might have a good effect. But if we would treat all the patients with psychosis with steroids, this might have many side effects. So I think it's very important that we select the right patients and to reduce this risk.
Brilliant. Well, at this point, I can't see any other questions. I know we are coming up close to wrap-up time, so I don't know, Dominique and Belinda, if there are any final thoughts or any final comments that you wanted to add on the. I mean, we've already covered a lot, and thank you very much. But any potential closing messages? I feel like I've learned a lot, certainly, but just for myself and other trainees tuning in today.
Do you want to go first, Dominic? I don't mind.
Yeah, it was a great pleasure for me to be part of this journal club. And I'm a little bit sorry for my bad English. I hope you understand it well. If there are further comments or questions, please feel free to contact me per email. And now I think we all will or should have a nice weekend. So I wish a great weekend to everybody here. And it was very nice to see Belinda again and with you, Professor Dr. Hamilton Marine. It was a very nice presentation. Thank you so much.
Yeah, no, well, it's lovely to see you, Dominic, always, and it was a great presentation, Hamilton. I suppose I wanted to say that I think this is a really important paper. We're actually way behind Germany, and at the moment we are running a double-blind placebo-controlled trial of intravenous immunoglobulins and rituximab in patients with psychosis and antibodies. I don't think you'd be able to do this study in Germany because they've moved on. They don't accept that there's any equipoise in whether you should treat patients or not. But in our system, we kind of feel we need that sort of gold label, gold top double-blind RCT to actually really change practice. So we are recruiting, and every single junior doctor on this call can help us by screening patients through our PPIP study, which is open to every single hospital site, and even patients that aren't under a hospital trust can take part. So you can go to our website, www.synapse.org.uk, and all the details for junior doctor training and for how to get in touch with the team are there. So that's my little plug. I suppose my final thing I want to say is congratulations to Tim Nicholson, who was awarded Academic Researcher of the Year yesterday by the Royal College of Psychiatrists. Completely well deserved, and it was absolutely lovely to see. So congratulations, Tim, and that's my final comment.
Brilliant. Thank you very much, Belinda, and thank you so much, Dominic. Thank you everyone for tuning in and giving up time on your Friday. Tim, I see you've appeared.
Yeah, blushing. Thank you, Belinda. Yeah. Great to see you. Thanks for your time, everybody. Well done, Hamilton. Great job. Bye, everyone.
And just one
Thanks,
final
Dominic.
plug. Well done, Hamilton. So we've got another journal club coming up on the 16th of December. Just a shout out. So it's a monthly international meeting. Next one will be 16th of December, and it'll be very interesting, looking at Parkinson's disease with visual hallucinations. So please look out for the meeting for that 16th of December. Thank you.
Yeah, and Dominic, do get your colleagues in neuropsychiatry to get in touch about presenting a case as well, a paper. Bye, everyone.
Thank you. Bye.
Very much.
Thanks, everyone. Bye. Well done, Hamilton.
Bye.